Good afternoon and welcome to today's Link Senior webinar. Just a few housekeeping items before we begin. Today's webinar is providing one NAAP and one NCCAP CEU credit. To be eligible for the CEU credit today, you must stay on the webinar for the full hour. At the end of the webinar, I will provide the required post-webinar survey evaluation link in the webinar room chat box, and I will also send it by a constant contact email message. Please be sure to check your spam folder for that. You must fill out the survey no later than midnight this Thursday, March 21st, to be eligible for the CEU credit. If you are not looking for CEU credit, we do want you to fill out the survey as well because we would like to hear your feedback. Don't forget that there's a PDF of today's PowerPoint deck in the handout section of the webinar room, along with some details about part 2 of this webinar, which will be held this Thursday, hosted by the Pioneer Network. At the end of the presentation today, we will provide a discount code that you can use to sign up for Thursday's webinar. Link Senior started providing these monthly educational webinars last year, and since that time, we have had more than 4,000 people participate. At the end of the webinar today, we will be sharing a list of the upcoming 2019 speakers so that you can save the dates for those events. This is a look at just some of our past speakers over the last year and also feedback from webinar participants. We are always looking for new ideas on webinar topics and potential speakers, so please email your thoughts and suggestions to us using the email on the slide. Link Senior currently has more than 300 clients in the United States and Canada, and this is just a snapshot of some of our current partners and supporters. We are also doing some exciting research. These are preliminary results from a study of 3 long-term care and memory care communities in Toronto, which shows that being highly engaged in recreational activity is associated with increased cognitive functioning and social engagement, as well as decreased aggression and antipsychotic medication use. This research work that we have done was funded by the Baycrest-led Center for Aging and Brain Health Innovation. Today, we are very excited to have Dawn Worsley, the president of the National Certification Council for Activity Professionals, with us. Dawn is a national speaker, certified activity director, dementia practitioner, and Eden Alternative Associate. These are the objectives that we will be highlighting and achieving throughout the webinar this afternoon, and I will now hand over the presentation to Dawn.
Great, thank you, Megan, and welcome to part 1 of our program. So we're going to talk about what is person-centered engagement and how can you create a person-centered engagement program in your community. Now, this is one of those hot topic words that started quite a few years ago and that we hear diluted through the industry, but it is so extremely important that we understand what the concept is. In 2001, the Institution of Medicine put out a semi-annual report called Crossing the Quality Chasm. Person-centered care was identified as an essential foundation for healthcare quality and patient survey, and reviewed ever since. It's been recognized as a high priority for the delivery of healthcare services in many jurisdictions. Edith Ballant in 1969 defined what patient-centered care was as an understanding the patient as a unique human being. And that is truly what we're going to talk about today through recreational engagement. So every community has a case mix of the same type of resident. We have the residents who are alert and oriented, who prefer to engage independently in their room or on the patio, but not so much in a structured program. We also have residents who are alert and oriented, but extremely social and attend a variety of different programs and services that the communities offer. We also have residents that have cognitive challenges. Now, this is where we tend to see the biggest breakdown in services. Many communities still function with one activity calendar. And we try to make that one 45-minute or 1 hour long activity fit for every realm of cognitive and physical type of resident. And that's where the challenge begins. And hopefully through the next 45, 50 minutes, and as well as part 2 that's given on Thursday, we'll put this all together so that you have a game plan that you can then initiate within your community. These residents that have cognitive challenges and residents that have sensory needs, this is your most vulnerable population. This is the population that is unable to plan their own day, that is dependent on us as a community to actively engage and enhance and create a quality of life. So we need to make sure that our community looks and has programs that match the individual interests and abilities. Next slide, please. So how do we do that? Well, we've got to get some planning and development. Everything starts with a good plan. I've always said that if something does not function well in a community, it's either a breakdown in a system or a process. So FTag 641 is one of the tags that we'll go over tomorrow a little bit more in depth, but this tag talks about resident assessment. So if we go back to what the definition is of person-centered care, it's treating a resident like a unique human being. And it all starts with a good assessment process. The two departments that drive resident assessments with the detailed of who someone is as a unique individual comes from primarily activities, but also there are some questions that social work may ask. So one of the challenges that I'm going to I'm going to pass off to you is to critically look at your activity assessment that you're currently using. Does it give you the ability to be able to capture this individual as an individual human being? So for example, you want to make sure that on your assessment, it doesn't just ask the typical questions, do you like music, but how do you want to engage in music? Do you like to listen to it privately in your room? Do you want to listen to it in a group? Do you want to sing? What music? What artist? What genre? The more information that you capture onto an activity assessment, the better you are able to implement a person-centered engagement plan. Capturing that and then also changing the culture within a community so that every resident is a unique human being versus the feeder in 108 or the new hip fracture that just came in last night. So the first thing we need to do is create a culture within our community. And some of the ways that we do that are taking a look at our vision and our mission, making sure that we're addressing and incorporating diversity in healthcare and patient engagement or resident engagement, resident and healthcare provider rights. So our staff need to understand what are resident rights alongside of what our residents do. We need to have a consistent operational message that really starts from the top down, from our administrator, director of nursing, and director of activities. We need to take a look at co-designing the development and implementation of our education programs. Integration of all healthcare sectors and professionals. Sometimes we do ourselves a disservice in our communities, and when we're talking about programs like this, we tend to only gear the education towards nursing assistants, maybe social work, maybe activities. But there is an entirely untapped resource out there which is your environmental services, your dietary staff. If you truly want to talk about a social model of care and person-centered engagement, ask your housekeeper about Miss Smith, and I guarantee you they can tell you the new card they got, a picture that their grandchildren sent, or a visit the last time their daughter came in. So we want to use those to our benefits, because that's identifying who those key players are when we're trying to develop this type of program. We want to look at providing a supportive and accommodating person-centered environment. So collaborate and empower your residents and your staff in designing a person-centered engagement program, working directly with your frontline staff at the nursing assistant level, working directly with your residents. We want to make sure that our environments are welcoming, comfortable, and respectful, that spaces also provide privacy, that there's spiritual and religious programs that are available, that the facility prioritizes the safety and security of its patients, its residents, its staff, its clients, its customers, whichever word you use to define the wonderful people who are living within our communities. Take a look at the areas in the rooms, and do they support any accommodations that are needed by our residents? The next thing we're going to talk about in a few slides is organizing the activity department, and what does that mean. But for right now, we'll go on to the next slide where we focus a little bit more on the planning and developing and looking at assessing the facility strengths and weaknesses. Now, a brand new federal regulation, FTag 838, talks about facility assessment. And that facility assessment was most likely done by your administrator, your director of nursing. But as activity professionals, we want to make sure that we give input or provide resources as to the strengths and the weaknesses within the person-centered engagement program. Recently, we presented a webinar regarding the survey process through the eyes of a surveyor. And we had a local state surveyor help us write that education. And one of the things that he said about the facility assessment is, initially, your surveyors are going to go in and they're going to see if it's done or not. Just simply let me see it. But as they continue to delve in through the survey process, then they're going to look at, does the facility assessment actually capture, and does it work, because it should be a living document, does it work alongside the QAPI process? If you have, let's say, a high number of falls, is that identified in your facility assessment as a weakness? So this is a great opportunity to not only work in conjunction with the QAPI process, but to also show off the strengths of the facility with person-centered engagement. Also with the planning and development, we have to cultivate communication. So we want to make sure that we are listening to our residents, actively listening, training our staff to understand what active listening means. Because a lot of times it's just not the words that someone uses, it's also all the nonverbal communication that is displayed. Nonverbal behaviors such as eye contact, asking questions of residents so that we truly understand what they need, what they want. Residents are provided with all the necessary information to make informed decisions related to their diagnosis or their engagement options throughout the community. Responding to your resident and caregiver needs. We want to make sure that we foster an environment that is respectful and we have compassionate care, being responsive to preferences, needs, and values. Again, for long-term care facilities, Section F of the MDS is the customary routine and preferences. This is usually the assessment that is done within the activities department. You want to go back within your community and ask yourself this question: what do we do with that information once it's collected? If we know the customary routines and preferences of a resident, who do we communicate that to? How do we integrate it within the care plan? How do we communicate it to dietary or to nursing or to other rehab services. So things, again, to look at as we're looking in the planning and development. Providing supportive care, building a partnership with your residents, providing resources. We also want to engage residents in managing their care, co-designing the care plans with the residents. And that's important because, again, the new survey process is expecting us to not dictate to the residents what we feel their plan should be and what their goals should be, but work alongside the residents. FTag 656 is the development and the revision of a comprehensive care plan. And then finally, look at how are we going to integrate this care. Communication and information sharing for the coordination and the continuity of care throughout the continuum of care. Let's go to the next slide where we're going to talk about organizing the activity department. So here we want to be able to first break down our residents into different cognitive levels, working directly with the social worker or the rehab department, looking at sections such as Section C for the BIM score, and identifying the cognitive level, looking at the resident in a holistic view, and then deciding what type of programs or services do they need. We really have to redefine what the activity department is. Unless there is a physician's order that says a resident is to be bed-bound, I challenge you to go back and rethink the concept of, well, these residents need sensory activities. So instead of creating a sensory enhanced program, we'll continue with the status quo of the last 30 years, and we'll do room visits, and we'll do one-on-one visits. Now, I'm not saying that you're going to eliminate those services because there is a population that we know that just do better when there is no external stimulation and we can fully engage the resident in a quieter atmosphere when it's just you and them. But I will also tell you from my 30 years of experience and from actually implementing person-centered engagement programs for the last 15 years, that population of residents who need to be in their room is a much smaller percentage than what we may actually think. So once we've identified how many residents fit into certain categories, we need to develop programs for each level of that resident, keeping in mind duration of program, how much structure do they need, what kind of supplies, and we want to make sure that we obtain the right supplies. Not necessarily convinced that we want to do a small bead project with someone that has cognitive deficits and puts things in their mouth or has a decreased safety awareness. So we want to make sure that we're using the proper supplies that meet the cognitive level and the engagement abilities of each resident. Participation records. We need to take a look at not only organizing our participation records, but what information are we capturing on the participation record. Tomorrow, we're going to discuss exactly what the survey process looks like and how they tie in to the assessment, the care plan, the delivery of a person-centered engagement program, and we'll wrap up with what the surveyors are specifically looking for on participation records. We need to work directly hand in hand with nursing to develop person-centered schedules for each resident. We have to provide structure for those residents who are unable to plan their own day that are specific to their individual needs. And again, in a few slides, we'll go through exactly what that looks like. For now, we're going to go on to the next slide, and we'll talk about some maybe roadblocks that might prevent you. Other things that take your focus off of a person-centered engagement program. Now, we always want to make sure that we are not reactionary in nature as much as possible, but that we are proactive in the programs. We need to make a commitment, and that, again, that commitment level starts with the administrator. director of nursing, and the activity director, that this will remain a focus for your community to fully develop and engage in a person-centered activity program. The next roadblock is not necessarily putting in the prep work. Thinking that your community has already adapted to culture change. Maybe skipping the education steps that are necessary. Developing programs without getting the input of the nursing assistants and the floor nurses. The last thing we want to do is to hand the program, another task to our hardworking nursing assistants and floor nurses. If we make them part of the planning and development and explain to them the benefits of not only for the resident themselves, but also to alleviate their workload so that they can focus on more of the chronically ill residents that they have on their floor, you tend to get more buy-in. Equipment and schedule barriers. You will absolutely come up with roadblocks as you implement this. Things that may not have been an issue that all of a sudden you do. As soon as you take a unit within your community that's, let's say, 40 residents live in that community on that unit, and you break down the different cognitive levels and you've decided there are 15 residents that is going to rely on the community to develop a person-centered engagement plan because they don't have the ability to plan their own day. All of a sudden you'll find out, well, we only have 11 wheelchairs because not everyone got up every day. We would rotate them. Every community has the group of residents that they don't get up, that are sensory needs, that we have traditionally done one-on-one visits with. Helping the nursing staff understand how important resident engagement is, even for the resident who cannot speak, who is completely dependent. That is probably the number one resident you want to focus on. Because our alert and oriented and very vocal residents, they're going to, they have the ability to engage. They have the ability to plan their own day. But this most vulnerable population is what is critical when it comes to person-centered engagement. And you want to make sure that if I traveled to Morocco, and that was one of my favorite international countries, when I can no longer speak for myself, I would hope that that was communicated in my assessment, that it's part of my care plan, and that every day you bring in images, music, smells, sounds of Morocco to help me travel back to a time when I enjoyed when I was able to be a world traveler. And that's what it's really about. Fail to educate. Scheduling barriers. When we start to develop a person-centered engagement plan, we're going to realize that all of a sudden it's like, well, if we want programs to start at 10, that's what time we give medicines. Or we've got 3 nursing assistants that go on break at 10 o'clock. We can't do this. I'm sure if you went and committed to working with the team as a whole, you realize that there's very few medications that have to be given at a specific time. Reshifting how you do things. Remember, all these tasks that we must get done within our community, we control when they get done. So with a person-centered engagement plan, we start with the resident at the center. And then we build all of the other things that need to happen. Medication passes, shower times, therapy schedules, staff breaks, staff lunches. All of that revolves around the resident. What do they want to do that day? Where do they have to be? How are we going to engage? And how are we going to enhance their quality of life? So let's go on to the next slide where we talk about the multi-department approach to programming and identifying who these key individuals are. And it may be on each unit. It may be taking a look and who are going to be the champions of engagement. Who in your building just gets it? Just every day they want to know, excuse me, the very specific details of who Mary is. And they want to make sure that that becomes part of Mary's day and that everyone knows about Mary. So take a look at those key individuals. And then again, expanding out to all staff. We don't want to forget environmental services. There's two regulations that really talk about this multi-department approach to programming. And one is FTag 675, which is quality of life. And the next is FTag 679, which is the activity tag. So again, we're going to talk a lot more about FTag 679 tomorrow. But one thing that I want to make sure that we understand today is that activities is everyone's responsibility. That regulation is written that the facility must, not the person who wears the name badge that says activities director or activities assistant. And the number of deficiencies that are being issued under the new survey process, under 679, is higher than we've ever seen before. The deficiencies are being written that the facility failed to provide an ongoing activities program. Now, I'm very grateful that many of the surveyors are taking it a step further to give the facility a little bit extra knowledge and a little nudge to change the culture within their community, because a lot of the 2567s that we've seen have language that's written such as the facility has a fantastic activity program. However, resident 67 was found sitting at the nurse's station after lunch before afternoon programs and not engaged at all. That was displaying behavioral expressions of anxiety and fear and was left unattended. In a few more slides, we're going to talk about person-centered engagement toolkits and how they have become so critical for this person-centered engagement program, and that it can get everyone involved. It's very simple, it's cost-effective, and we'll talk about that. But I want to take a minute to talk about FTag 675, quality of life. So in the quality of life federal regulation, there are actually very specific definitions for both person-centered care and quality of life. They want to make sure that communities create and sustain an environment that humanizes and promotes each resident's well-being and feelings of self-worth and self-esteem. This requires that community leadership to establish a culture that treats each resident with respect and dignity as an individual, addresses and supports or enhances his or her feelings of self-worth, including personal control over choices such as meal times, activities, clothing, bedtime, privacy during visits, treatments, and the opportunities to engage in religious, political, civic, recreation, and other social activities. Community leadership must be aware of the culture that exists within their facility and may use various methods to assess the attitudes and values prevalent amongst its staff. These methods include viewing complaints or grievances, which could reasonably impact a resident's quality of life, or allegations of abuse, neglect, or mistreatment. In order to identify whether staff supports each resident's quality of life, the leadership should observe and evaluate verbal and nonverbal interactions between the staff and its residents. Negative observations could include staff actions such as the following: verbalizing negative or condescending remarks, refusing to provide individual care to a resident due to his age, race, cognitive or physical impairments, political views, cultural beliefs, or sexual preferences. Dehumanizes an individual through verbal or nonverbal actions, such as talking to others over a resident without acknowledging his or her presence. This is true in the dining room also. Treating the resident as if they were an object rather than a human being. And of course, the worst of mistreating or physically, sexually, mentally abusing a resident. So in order to achieve a culture and environment that supports the quality of life, the facility must ensure that all staff across all shifts and departments understand the principles between quality of life and honor and support those principles for each resident, that the care and services that are provided by the facility are person-centered, and honor and support each resident's preferences, choices, values, and beliefs. And that was taken directly from the federal regulation 675. So let's go ahead and let's go on to the next slide, where we're talking about how do you develop these person-centered engagement schedules. What does that look like? I do believe the first thing it needs to do is it needs to be unit-based. You need to work and treat every schedule and meet the specific requirements of the people that are living within that unit or that community. A couple of the FTags that really focus on or address person-centered engagement schedules and really unique to the human being. FTag 742, the treatment and services for mental and psychosocial concerns. FTag 744, the treatment and services for dementia. And phase 3 is coming in just a few months. November 2019 is when phase 3 of the rules of participation go into effect. And this is where we also need to then become experts in FTag 699, trauma-informed care. So let's talk through the process. Again, redefining your thought and redefining the roles of each activity person within an activity department. Many times I have went in and evaluated activity departments, and they've had 3 staff, 4 staff, but they've only ran 1 activity calendar. And they'll have their 9:30 activity, their 10 o'clock activity, maybe an 11 o'clock, a 2 o'clock, a 3 o'clock, a couple times a week, a 6:30, and then they've got their weekends. When you look at that, you're looking at how many hours of programming is actually offered on that basis versus how many staff hours we're paying that week. I can tell you that a person-centered engagement schedule can be built to have multi-level programming with no more than 3 full-time staff. So taking a look at what each role is. Again, we talked about a few slides ago, changing our view of what programming looks like for our residents who live within our communities. There was a time that we had this philosophy that we needed all of these one-on-ones, these bed-bound residents, because what could they do? What could they possibly do? They don't know what's going on. They can't do anything. I challenge you to look at someone's abilities versus their disabilities. I have learned from personal experience, one of the key resources within your community to help you find the abilities and customize a person-centered plan is the occupational therapist. So that occupational therapist can prove to be a valuable asset within your community. You want to create multi-level programs within your community. Now, not everyone has the space to be able to have 2 different programs or 3 different programs that run simultaneously in your building. If you do, that's ideal. But sometimes we have 1 room and everything has to happen within that one room. Well, in that case, we need to take a look again at person-centered engagement, and maybe we split the room. Half of our room is for alert and oriented residents, and they're going to run their schedule like we typically do with these large group calendars. We're going to have programs that last 45 minutes or an hour. But maybe in another part of the room or another location, ideally, would be where we would have programs for the cognitively impaired that change based upon their specific needs. So as a generalization, if the average attention span of someone with cognitive impairment is 15 to 20 minutes, then we want to make sure that we're developing multi-level programs that meet that 15 or 20 minute attention span. If someone is sleeping within the activity department and they've slept well the night before, they may be overstimulated or understimulated. So taking a look at matching the type of programs and type of engagement to the residents' cognitive and physical abilities. The survey process, which we'll talk about in part 2 on Thursday, I will tell you I just went through a survey with both state and federal staff, and about 90% of the residents that were chosen in the sample size were all residents who could not plan their own day. It was a significantly different survey process than what we have seen in the past, even under the QIS survey. So identifying for those individual residents. Now, when we're talking about building individual schedules, what I typically do is I make one book. I don't make lists and hang them up on the units, because these lists are going to change based upon our resident needs or our admissions or our discharges. And then the challenge is always, am I looking at the right list? Do I have the right list up there? So I would recommend getting a binder, clearly being able to identify it as this is your person-centered engagement plan. And then part of the regulations, again, says that activities needs to communicate with the nursing department as to how do we collaborate and how do we work together. What role does nursing play to ensure that the residents are successful in their person-centered engagement program? So nursing needs to be aware of which residents need to or like to come to certain programs or need to come in certain programs. And then I separate my scheduling book into 2 different levels. One are for my alert and oriented population who plan their own day. And that second page, I list out all of the residents who have the ability to plan their own day. And then I have certain columns. One column says, I have a preference to engage in self-directed activities within my room. Please just notify me as to what's going on that day. And I put a check mark next to those residents. But then I also have another series, and again, this is for the alert and oriented population, and I say, I like to come to large group programs, but I might need assistance to get out of bed, to go in my chair. I may need assistance to get into programs. And then I have 3 columns under there that separates morning, afternoon, and evening. And I check off which types of activities or times of activities that my alert and oriented residents like to go. I'll put on specifically, I like to sleep late in the morning for those residents that like to sleep in till 10 or 11 o'clock, but there are night birds, so they're up in the afternoon and up in the evenings. I've written on these particular schedules that, I really don't want to, I like to engage in my room. However, if you're having a party, I want to be there. So this gives a guide to the nursing assistants and the nurses as to each resident that is alert and oriented. So how do they offer? How do they help the resident get to where they want to go? Now, the most important part of this unit-based book are for those residents who cannot plan their own day. And then in that case, again, looking at individual schedules, the first thing we look at are residents that have falls, residents that display behavioral expressions where they're yelling out, maybe out of fear, but when they're engaged with someone, they're no longer yelling. So we take those residents, work directly with the nursing assistants and the nurses, and we start to identify when is this resident awake, and when would they benefit the most from being in a person-centered engagement program. Sometimes you have to start out slowly because you may have residents that have not been out of bed except the last time state survey has been in the building, or maybe it's been 3 months because of an illness. So you might want to start out and say, well, you know what? We want to ease into this slowly. So maybe we'll start and we'll coordinate everyone's shower days. And on the days that they're scheduled for a shower, before the shower or after the shower, we'll get them in a person-centered engagement program. Of course, with the goal to increase that person-centered engagement as much as possible. Guidance, again, would be input from nurses and a nursing assistant. Nursing to adjust staffing schedules to provide guidance and assist with prioritizing their assignments. This is where your floor nurses become a valuable asset in helping the nursing assistants plan and be able to prioritize their day. Let's go on to the next slide where we talk about care planning. Now, with the electronic medical record, a lot of pre-canned care plan packages were sold to organizations with very little person-centered language within these care plans. Truly, they need to be individualized and address specific resident needs that go in coordination with the MDS Section V. Care plans should not read that residents will attend activities 3 times a week. It is not as important as how many times we can corral them in a room, as much as what is the engagement, what is the outcome we want to achieve through the person-centered engagement. So what is this going to require from our communities? It's going to take a look at what does this canned care plan library look like. We may need to make sure that the activity directors have the ability to customize care plans based on those specific needs and to be able to individualize them. I'm often shocked when I talk to activity directors who say, my company doesn't allow me to write a care plan. I must choose from the 3 that are in our library. And I will tell you that as we go through the survey process and our surveyors become more savvy in regulating what FTag 656 means, that could potentially be a problem. The other thing you could do is completely rebuild a library that promotes individualized care plans and are interdisciplinary in nature. I and the company that I work with, we have 4 choices under the activity care plan for activity-related care plans. However, we have a total of 28 care plans that are peppered through the process. So if someone has a cognitive deficit and that's the activity benefit of engagement is to work on someone's cognitive level, then they would go under the care plan library of cognition and they would choose the appropriate activity-related problem, goals, and approaches. So we have these under, just to name a few, cognition, behaviors, falls, pain, psychosocial well-being. The next slide we're going to talk about, again, are roadblocks. So we'll go to the next slide. Change starts from the top. A truly successful program always make sure that we have the administrator, the director of nursing, and the activity director on the same page. That we all have a shared mission of enhancing the quality of life through person-centered engagement, that we are going to break down the barriers and change the culture within our communities to ensure that this is successful. The administrator is going to set the tone for the success of this program. They're going to set the expectations of every department and who is going to participate in a resident engagement program. The director of nursing is responsible for helping work through and develop individualized resident schedules for the purpose of person-centered engagement programs. So they're responsible for making sure the residents get there. And the activity director is responsible for making sure that we have quality programs that match the engagement needs of every resident within our community. We need to take a look at the assessments that we do, interdisciplinary. So not just the activity assessment, but holistically as a group. We want to make sure that the assessments truly reflect a resident's current status. Team members who say, I can't attend, I can't be part of this, I'm too busy. We want to make sure that even our best intentions, and yes, everyone is busy, and yes, to really create a person-centered engagement program, if you don't have one, is a much different mindset than where you were before. And this is where, again, putting the effort into educating and getting input from everyone, getting that buy-in will hopefully eliminate or decrease when team members say that they can't attend or a resident can't attend. I've heard plenty of times that where I've heard from other departments, well, that resident can't go because they're a fall risk. Well, I'll tell you, activities is one of the best non-pharmaceutical interventions for falls. When we are consistent in a resident schedule and we have a person-centered engagement plan that holds the interest, that matches the ability of every resident that we engage with. The other roadblock is residents who don't get to their scheduled programming. And stepping back, and again, you will have these roadblocks, but stepping back and instead of it just accepting, oh, well, they're not doing it, or, you know, I knew this wasn't going to work, or whatever, sometimes we get frustrated and we verbalize and say, we need to step back and look at the root cause. Why aren't they? It might be as simple as we don't have enough Hoyer lifts. We don't have enough Jerry chairs. 11 to 7 didn't get anyone up. Or we didn't think about having 11 to 7 get some of these early risers up. So there are reasons why residents don't get to programming. Sometimes it's because the nursing assistant didn't do it, the nurse never looked, the unit manager never commented. So if it's not a priority to my bosses, why is it a priority to me? Sometimes team members disagree with the schedules. Oh, they can't be in that program. Do you know by the time they get back to the unit, they're so tired, it takes 2 of us to get back to bed? Well, safety is always first, but my question then is, well, how would you like them to come back at the end of the night? I would want them tired. I would want them having so much fun, engaged, so exhausted that they're going to sleep throughout the night instead of being wide awake. So sometimes we need to do that. Sometimes we need to help bring a staff member who is having trouble seeing the little changes in a resident in a person-centered engagement program, where in their eyes they think, and it's legit, so there's no judgment, well, why am I getting this person up? They can't do anything. I mean, I walk past the program, all they do is lay there. Now, from the eyes of someone who's engaged in that resident, those tight muscles around the eyes relax. There's a smile. There's a toe that's tapping. Sometimes staff need to see that to help make the connection of how important person-centered engagement is. And then again, participation records, that either we don't capture what we are providing, or we don't capture the level of engagement, so therefore it becomes difficult to track whether we're successful or not. Let's go on to the next one and start again talking through, because I think sometimes if we talk through all of a sudden what are some of the roadblocks you may come up with, when you're ready to implement a person-centered program, you're going to say, oh yeah, they told us we were going to come up against this. So it's not a surprise. Fear of failure from staff. And that's really big. Really, I mean, we have the best staff in the world. This is a mission-driven organization. You know, goodness gracious, we know we don't do it for the money. So we do it to make a difference in someone's life, no matter what position we hold. And sometimes we're fearful. If we can't do it 100%, we're not going to do it at all. And we want to let staff know that the only way we're going to grow is sometimes through our failures. Family members can be a roadblock. Maybe not ready to accept where their loved one is with programming. Maybe scared that if we get them out of bed, they might fall out of bed. They might fall. They might hurt themselves. It's too much. They can't do anything. So it goes back to that education. Sometimes it could be nursing, the philosophy that this is a medical model of care. Oftentimes you lose key staff, and I've worked through that process several times where we have had the programs went wonderful, and then our director of nurses moves to a different state, and we have to get the new director of nursing back up, or we change a unit manager. So that could be an issue. Residents developing problems from being up and active. They think they can do a little bit more than they can. Get rehab involved. Rehab's going to help great when it comes to seating and positioning and safety. Also, rehab's going to do great with being able to help with that adaptive equipment that you might need for a person-centered engagement. Let's go on to the next slide, which is non-pharmaceutical interventions. Person-centered engagement toolkits. So person-centered engagement toolkits are something that we've recently implemented to meet the rules of participation for non-pharmaceutical interventions. And the basis of this is that behaviors are nothing more than a means to communicate an unmet need. When residents experience behavioral expressions, our staff will begin to identify the basic need of the resident. When the basic needs have been ruled out, such as toileting, pain, hunger, then they will be given their personal engagement toolkit. This toolkit is personalized and customized to the resident. So some of the things that I've had in a person-centered engagement toolkit are sensory balls, or stuffed animals, or a photo book that we've put together of France, or crossword puzzles, or mandala coloring kits. So these become very important. And again, tomorrow or Thursday, we're going to talk about what the surveyors said about these person-centered toolkits. Let's go on to the next slide, because the only way we're going to perfect this program is going to be through the QAPI process. Do not expect perfection. FTag 865 talks about the QAPI program, the plan, the disclosure. FTag 866 talks about the data collection. So this is going to be an ongoing process. FTag 867 is the improvement activities. So you'll have to, and I do suggest that we keep a person-centered engagement QAPI program in place for the first year until you're successful. You're continuously to be successful, because you're going to find that this is much different than what you've put in place before. If we could go through to the next slide. Top 3 barriers: loss of key staff. The momentum fizzles. It becomes the mundane. Sometimes this is driven by management, family and staff perceptions. If it's important to you, it'll be important to your staff. So I definitely want to say that one thing to remember is that culture eats change for breakfast. So I'm going to repeat that again. Culture eats change for breakfast. You cannot institute change until you have fostered a culture to accept the change. And this is quite different than what we have been doing in the past to truly do it right. Let's go on to the next slide where we talk about curb appeal. Because not only does this elevate the quality of life, the quality of care of your residents, it will empower your staff to be creative. You can then build on this, and you can then look at how am I going to enhance my meal service programs? What other special events? This truly becomes a marketing venture around the person-centered engagement plan. So the next slide, I'm going to give you some resources here to take with you. And one is NAAP. NAAP is our professional association, the National Association of Activity Professionals, and it is a $75 membership. There are a lot of toolkits in which you can use. They also, specific to activity professionals, are bi-monthly webinars that they have in their library that can be used for renewing or obtaining your NCCAP credential. As the president of NCCAP, it wouldn't be anything but me if I didn't finish up by talking about how important it is to elevate the standards of the activity staff, to make sure that we have sufficient and competent staff. Those competencies are going to be part of phase 3, taking a look at our activity staff, elevating the competencies. We have an activity professional certification, activity director certification, activity consultant certification, and you can find out more information and learn about how to take the educational requirements through NCCAP. So a thank you. This is my email address. If there was something that you wanted to learn today that we didn't go over, by all means, please feel free to email me, and I will get you that answer. And I look forward to being one of your 3 speakers for Thursday and coming to part 2 of this. Thank you.
Dawn, thank you so much for your time today. And as Dawn mentioned, the Pioneer Network is having a follow-up to today's webinar, which you will be able to access for just $25 by using the code ENGAGEMENT. And the hyperlink to the registration form is currently on the screen. So we hope you'll join the Pioneer Network on Thursday for that webinar. Dawn, we did have one question come in, and I know we have limited time here, but someone has asked if you could talk about a specific example in which you faced a roadblock in your work and experience and how you addressed that.
So I think our biggest roadblock was equipment. We always, before we implemented a person-centered program, we always rotated residents. Everyone got up. But when we truly changed the culture to ensure that every resident had the same right to be up and engaged on a daily basis, we realized that we needed to manage our resources because we had enough Hoyer lifts, but as like most facilities, they were being stored, so in fear that we wouldn't have enough for the next shift, or we had to change the rotation of pickup of laundry time so they could be laundered more often so that we could rotate them through. And also taking a look at seating and positioning. I think that was the biggest roadblock. Once we corrected that roadblock, we eliminated that problem, we continued to work on, and there were other roadblocks, but we continued to address each roadblock. We never found a barrier that we could not overcome. So hopefully that helps.
Definitely. There's just a couple more quick questions here, Dawn. So someone asked if they could see a copy of the binder that you mentioned making for your person-centered activity schedules.
So if you email me, I can send you, it'll have names like Mickey Mouse and Donald Duck, and it'll have some blank templates that you could play around with. But I do have just some templates to take a look at and customize. It's all about customizing it for your community and for your population.
Excellent. And finally, someone would like to know, are the residents who are self-pay still expected to be on a person-centered care plan?
If they're self-pay, is that what you said, self-pay?
Self-pay, yes.
So in a long-term care facility, how someone is paying for their stay Again, long-term care, so assisted living and how things are built in may be a lot different. So let me address what I am an expert in, and that's long-term care. Long-term care, it doesn't matter what your payment source is, whether you're private pay, you're no pay, you're on a scholarship, you're Medicare, or managed care. Everyone is entitled and to receive the same person-centered engagement plan. If you were on a fee-for-service type of program in an assisted living or an independent living, that would definitely be at the discretion of your community, I would assume. And they don't follow the federal regulations. Nursing homes are the only ones right now following federal regulations.
Excellent. Thank you, Dawn. And some participants on the line have asked to see your email address once again, so I've put that on the screen.
Wonderful.
I do want to remind everyone as well that we're having our next webinar on Tuesday, April 23rd at 1 p.m., and that's going to be featuring author and activist Ashton Applewhite. We'll have one free NAAP and one free NCCAP CEU credit offered that day. And Dawn, thank you so much for your time today. I have put the CEU survey link in the chat box in the webinar room, and it will also be sent to your email address this afternoon, so keep an eye out for that. And with that, I wish you a great afternoon, and thank you for participating today.
Thank you. Have a good day.
You too.